Hello, I'm Lauren Evans, speech pathologist, certified lymphedema therapist. Okay, this is my last episode this morning before I go and decide. For those of you who've been following me, my husband and I are fixing our roof. We've decided that I'm not a speech therapist this weekend. He's not a assistant store manager this weekend. We're going to be roofers. All right, so here soon. You guys will not see me because I will be climbing ladders and being yelled at by my husband to pull up shingles or move a board or find the pry bar, not the hammer, etc. It's fun stuff. So, but before I wake him up to get back to our roofing project, I want to talk to you specifically about something today that's going to be our continuation of our patient who's coming to us, the 76-year-old with the base of tongue, lymph node involvement of the neck. That lymph node involvement was treated with chemo and radiation therapy. We're now going to take this patient, and this patient's completed their treatment, okay? We talked through sort of what the fear looks like of a feeding tube, and that was in episode 5. We talked through in episode 6, what does it look like in weeks 4 through 7 for them? And now in episode 7, I'm going to take that same patient, and they're coming back to me weeks 4 to 6 post-treatment. So I also like to call these week 11 through 13. Why? My typical patient has week 1 is treatment, week 7 is completed treatment. Now they have side effects. They're done with treatment, but they've got side effects. Week 8, week 9, week 10, week 11, they're starting to improve. Week 12 and 13, they're typically ready for me, okay? I didn't make that up. It's evidence-based practice. So if you don't know your science, you need to follow the literature, okay? You need to follow and review what does the current literature suggest in our role as speech pathologists. You need to follow your mentors, okay? I follow very closely the MD Anderson work. I'm a big fan of Dr. Kate Hutchison's work that she does. I'm a huge fan of Brad Smith and all the work that he's put out for us as speech pathologists and lymphedema therapists. So, that brings up sort of a side note before I delve into our patient. If you are not trained as a lymphedema therapist in the head and neck, go and get the training. What are you waiting for? Okay. So I encourage you to consider taking the training. The trainings that I took included the Norton course as well as the APOLS. My first course was Norton's course on head and neck lymphedema. I was lucky enough to have Brad Smith before he retired. And then I included to go through the APOLS course, and that was a wonderful course for the full complete decongestive therapy. But as a speech pathologist, there's a lot of debate of if we need that, CLT license, that complete lymphedema therapist license. Do we need that? The CLT, I don't know. It taught me a ton. I love to learn. So Marina was amazing. So I think that connections are a beautiful thing. I think that education is an invaluable tool to invest in if you decide that you enjoy the head and neck cancer patient. If you do enjoy the head and neck cancer patient, I will tell you, you should understand lymphedema. And if you are not trained in lymphedema, you should push your facility to consider offering that for you. If your facility is not willing to pay for it, just pay for it yourself. I think that there's sometimes this high horse we get on as therapists. Well, I'm not paying for that. My facility needs to pay for it. No, they don't. Go pay for it yourself, all right? Think of all the things you've invested in that have changed your life, right? Lymphedema education is a life-changing for not only you, but all the patients you will serve, all right? So that's my side note. Now get back on track. Now, here we go. Patient is 4 to 6 weeks post-treatment. They come into my clinic, and I am seeing maybe a little bit of lymphedema. The most common timing for lymphedema is 6 to 12 weeks post-treatment, all right? Now, at this point, I've taken my neck composites, my superior, my middle, my inferior to get my total neck composite, visit 1. So when the patient first came to me, I've taken photos. Now here I am post-treatment. I'm going to take the neck composites again. There's something that's very important to understand. If your patient has lost weight through the course of this treatment, you're not going to have consistent measurements, which they likely have, right? But you need to still continue to utilize those measurements. Now, the measurements that I use from the beginning are Brad Smith's measurements, and those are found in the Norton course if you haven't taken it. They're also, if you haven't invested in this lymphedema management book, you should, because they're in here, okay? So hopefully you have learned and practiced this in clinic. And if you have not, I encourage you to take the course so that you can learn the measurements. The second set of measurements I take are the facial measurements. Why would I be taking my patient's facial measurements? Well, it's really important. The facial measurements are going to give me an idea of swelling on which my pathways, submandibular and submental, are impacted, okay? So let's review. My submental pathways are going to drain to my chin and my lower lip. My submandibular pathways are going to drain to my lower eyelid, my nose, my cheek, my upper and lower lip, and my lateral chin, okay? So you have a patient who's been radiated straight here to the submental, submandibular lymph nodes when you're involving levels 2A and 1B. You have that patient who has been impacted here. The cancer is hopefully gone, but we don't really know that until they've received their PET, right? So I'm seeing my patients 4 to 6 weeks post-treatment. I'm measuring them. If their skin integrity allows me to touch it, I'm measuring them. So I get their measurements and I am starting to rehabilitate their swallowing in terms of making sure, are they ready for an objective study? If they're not yet ready for an objective study, when do I anticipate they will be ready for an objective study? Usually it's within 4 weeks. I try to get my objective studies based on my clinical findings. So let's pause there. Patient comes into me. That particular patient is 4 to 6 weeks post-treatment. Let's say there's 2 pathways. This patient made it through treatment by drinking Boost and Ensure. They did not get a feeding tube. They're still drinking their Boost and Ensure, and they're starting to try to want some solids, maybe some yogurt, maybe some smooth and creamy things. So, sorry, I took a sip of coffee. Let's hope that that sip of coffee settles my reflux. So that patient is 4 to 6 weeks post. They're coming into us. The first pathway is they have continued to swallow through their treatment. Much, much easier to get an objective study. They're going to also be ready for an objective study quicker than the patient who has the feeding tube, in my experience, okay? 2 courses of objective studies. You can either fiber endoscopic swallow study them, or you can send them for a modified barium swallow study. At our clinic, we have a FEES. I invested in a FEES when I kept having all of these patients come to me, and I kept having to wait for the hospital to give me MDSs, and then nobody at the hospital would sort of assess the idea of lymphedema. I needed to see the internal structures myself, because internal edema is a real acute side effect. Guess what? Myself, as a over-ambitious speech pathologist, cannot treat internal edema, okay? If my patient is struggling with the idea of internal edema, it doesn't matter what I do for them. Unfortunately, there's no science to tell us that we are going to fix this. Now, you will pull the literature and you will see some debates on that. But currently, there is no literature that suggests if I do effortful swallow, compression garments, compression pumps, if I do, swallow loading, NDTP, which I'm certified in each of these, so I want you to know that I can have an opinion of them. And I use them, but I use them appropriately. Weeks 4 to 6 with internal edema is not a time that I'm going to be pushing the idea of eating, typically, okay? You have to allow the time to understand what's happening in the internal structures before you start to push the external. So, two very, very important concepts here that we're sort of talking about. The first concept is the idea that my patients coming to me 4 to 6 weeks post-treatment, they're still swallowing liquids and they want to start to swallow a solid. So I'm going to give you an example. Patient takes a bite of applesauce. I don't know why speech pathologists love applesauce, maybe because it's cheap and it's easy and accessible, but we do. They take a bite of applesauce. The first thing they do is they try to swallow. And they typically regurgitate it back into the mouth, spit it back into a napkin. Why? Well, if you have a FEES, you're going to have looked inside that patient's throat. You're going to see that the shape of the epiglottis and the edema of the pharyngeal wall is going to be something so significant that they can't move the bolus up, over, past, through to get it down into the esophagus. The edema may be so significant and severe that there's no room for that bolus to flow through without them chugging and washing it down. And guess what they're doing all along the way? Right? Yes, this is a real thing. Your patients are still choking on their saliva. They're still choking on their applesauce. They're still choking when they drink their boost. And remember, just because they're choking and aspirating doesn't mean I'm going to stop, but it means I'm going to respect where they are in their acute healing process. Now, the other thing I want you to think of is you've assessed the internal structures, and let's say you don't have a FEES. Well, guess who they see week 4 post-treatment? Their ear, nose, and throat doctor. Guess who looked in their throat usually week 4? Their ear, nose, and throat doctor. So if you don't have a fibroendoscopic swallow that you're dropping in your patient's nose, you're going to pick up that phone and you're going to say, hey, Dr. ENT, what's going on inside my patient's throat? How is the edema? How is the internal swelling of the pharyngeal wall? How is the internal swelling of the superior pharynx? How is the internal swelling looking of the molecular space of the supraglottic space? And guess what your ENT is likely going to say to you? Pretty high, Lauren. Not looking real good right now. And I'm going to say, perfect, okay. So I'm going to tell my patient, I'm going to reassure them. I spoke with your physician. Your physician says, you look good in there, but it's still swollen. This is all normal. It's to be expected. We have to allow additional time before we begin to push you. So that's going to be one of my first pathways. Now, let's say I get really lucky, and this is a patient who is able to swallow certain pureed consistencies with multiple swallows, 3, 4 swallows. I'm going to start that, okay? I'm going to encourage my patient to do what they can. I'm not going to hold them back or restrict them. I'm going to do that. But I don't do it without an objective study. I will tell you that. I'm sort of a little bit of a brat about that. So if you can understand weeks 4 to 6 post-treatment, and you can understand that you're assessing two things when your patient comes in as a lymphedema therapist. You're assessing the internal edema, either via fibroendoscopic swallow. There's also studies with a modified barium swallow study. Get the images of your MBSs. Do you know how many times I've sent my patient for an MBS and the speech pathologist either hand wrote the report or, and we have, I see patients not only in rural areas that, really science has not caught up to what it's capable of. In the university setting, it's a beautiful thing because I get these lovely images of their neck. In one of our community hospitals, I also can ask the speech pathologist, may I please have some images of what does that modified look like? Can they be inserted in the report? But in some of our other community hospitals, I get handwritten modified barium swallow studies, AKA the reason I said I'm buying the fees, okay? So if you can get images, then you need to be looking at spacing, and you need to be looking at the idea of what does the internal edema visibly look like at this point. So I've assessed internal edema, either a FEES or an MBS. Now I'm measuring external edema. Usually weeks 4 post-treatment, I'm not seeing a ton of it. Week 6, I may start to see it. And by week 12, it's pretty rip-roaring glaring. So I want to encourage you that you're not just taking pictures of your patient. You're not making mental notes of your patient. You're being objective, methodical in your treatment sessions. Yes, you take a photo. Yes, you do measurements. If your team has set you up for a 30-minute treatment with this patient, you better be flying through it. We typically schedule our patients for 45 minutes because there's so much we need to get done. To be honest, I wish we could see them for an hour. One of the limitations in our clinic is that we're very heavy insurance-based. Unfortunately, I will say that cuts some of our sessions. If I were to go back and restart my private practice, I would probably consider not taking insurance. But I'll tell you one of the challenges. When you work with the head and neck cancer population, they want to use their insurance. It's very expensive to go through treatment. So there's a fine line between, did we make the right decisions as a business versus what's the best care I can provide for my patient. So I've taken my external measurements. I'm utilizing Brad Smith's measurements. Thank you, Brad Smith, for all of your work there. It's phenomenal. It's amazing. Don't cheat. Don't cut off 3 minutes because you want to just measure from the mandibular angle to the nasal wing, or the mandibular angle to the corner of the external eye, or mandibular here to the submental region in mentalis. Don't cheat. Do all the measurements. Okay, it's very, very important for your patient in the future. You're doing them on both sides, all right, your left and your right side. For your neck, you're getting the whole thing, right? So that is my goal today, and sort of helping you to understand the idea of lymphedema versus edema. So we're starting to see that the edema is going to be coming and turning into lymphedema, okay? Edema is an acute side effect. Lymphedema is impacted lymphatics, disrupted lymphatics, disrupted highways, blocked pathways. We're about to delve into that. All right. I hope that was helpful. Wish me luck today with my roofing exploration, and you guys have a wonderful rest of your day. Thank you.